Hello, my name is Marty O'Shea, and welcome to another edition of the Superintendent's Corner. Today's topic focuses on managing pain in student athletes and what options our student athletes, our teenagers, might have when they are experiencing pain. And today with us is a distinguished panel, beginning with Dr. Gila Sabetti. Gila is a neuropharmacologist from Western New England University, the College of Pharmacy and Health Sciences. Also, Dr. Al McKee joins us from the Pain Management Center at Bay State Medical Center. He's a palliative medicine specialist. And perhaps a familiar face increasingly in the community is Mr. Paul McNeil. He is the coordinator of our Drug-Free Community Coalition, which has had a very successful start over the last year in engaging community partners in bringing folks together to talk about prevention and intervention. So thank you all for joining us. So certainly pain management is an important topic for our student athletes here in Long Meadow. We have over 700 of our students participate in one sport or another at Long Meadow High School. It's close to 80% of our student population. So and naturally when they are involved in their athletic pursuits, they might come across situations where they need to relieve some acute pain or perhaps typical pain. And even beyond that, obviously teenagers have all kinds of experiences where they might need to manage their pain, perhaps as a result of a trip to the dentist. So Dr. McKee, Dr. Sabetti, and Mr. McNeil offer a lot of expertise in this area, and so we're happy to have them join us today in the Superintendent's Corner. Maybe we could start with just simply an understanding or a discussion of what is pain, because I know that in your conversations in the community that you have often started with that and kind of convincing us that it's important that we all understand the nature of pain. So would someone like to get us started?
Well, I think that we need to begin with the idea that pain is a natural thing, and it's actually a very important thing that we all experience pain. And there are individuals who are unable to experience pain either because of a problem at birth or something that develops over time. And actually, people who don't experience pain can experience significant injuries and have complications of not being able to appreciate pain. So the concept behind pain is that we want to be able to respond to something in our environment that's causing us harm. And if somebody touches something hot, we would draw our hand or our body part, and in so doing, we remove ourselves from the danger. But also, after you've had an experience that has caused an injury, pain reminds us to take it easy and allow ourselves time to heal. The natural history of pain is to go away. And acute pain is really the kind of pain that we deal with when somebody has had some type of trauma. And it's generally the pain that is experienced from minutes after the injury to about 2 weeks. And then after that, we think about subacute pain, which is the pain that occurs from about 2 weeks to 3 to 4 months. And most of what we're going to be talking about today is how we take care of people who have pain in the acute category and sometimes pain that has progressed to the subacute category. And that type of pain is treated very differently than how I treat pain in many of the patients I see who have chronic pain and come to see me at the Pain Management Center.
Thank you. And so often when people think of relieving pain, increasingly our attention, at least in the national media and local stories even, focuses on the role of opioids. And certainly you're more familiar than I with the problems associated with the misuse of opioids, or perhaps the misprescription of opioids and the associated addiction problems that come with that. Can we talk a little bit about the role of opioids in pain management, particularly as it relates to teens who might be experiencing pain?
Yeah, that's a really key question. I think one of the myths that people believe is that opioids provide the greatest, they're the most powerful pain relievers that we have out there, and they are the best options, because they provide they are the strongest pain medications. And more studies that date back to decades are showing that that's turning out to actually be a huge misconception, that we have better alternatives, and that when it comes to opioids, they do really have a very limited role in treating non-cancer types of acute pain. It's never fun, to experience pain, and but it was kind of a wonderful thing to hear that 70-80% of Long Meadow High School students are participating in sports. That's an amazing thing to hear. But that also means that that's probably associated at some point there's going to be an injury, and it's not fun for parents or for the kids themselves to be experiencing pain, but to understand that we have treatment options that involve not only medicines and non-opioids, but there are also non-pharmacological interventions in alleviating pain is a very important education point for everyone to understand.
Would you say, and we can come back to that question again, but would you say that that limiting exposure to opioids is especially important when you're talking about younger people, the teenagers who are still in the process of development? Is the exposure stakes higher for younger people than it is for people that are fully grown adults? Is that a different equation
and
there?
I'd love to add on to that, how significant is, and you both spoke to this beautifully a few weeks ago, but how important is family history in knowing, is my child at risk for potential opioid use disorder? But I'd love to hear your thoughts on that.
Science at this point tells us that 40 to 70% of the risk of an opioid use disorder is genetically determined. The next most important factor is the age at which somebody is first exposed to opioids. So that means that, especially in women less than the age 23 and men less than the age 25, exposure prior to that time is associated with a higher risk of out-of-control use. And if a person has a history of personal trauma, or if they have an emotional problem or a mental health disorder, also increases the risk of out-of-control use. So out-of-control use is not something that somebody ever plans. It's not a behavioral thing that is a character flaw. It's really a genetically driven and environmentally determined condition, risk, and we have to respect that. So when we think about treating somebody with an opioid analgesic, we think carefully about their individual risk. And fortunately, we don't have to think too much about that for the management of most acute pain, because most acute pain doesn't need to be treated with opioid analgesics.
When it comes to brain development, we know more and more that the brain of teens and adolescents are undergoing such rapid, profound changes. There are processes of, synapses and connections are being laid out in very precise manners. And the age of an adolescent brain, Dickens knew exactly what he was talking about as far as brain development. It is the best of times, it is the worst of times. It is the age of wisdom, it is the age of foolishness. And that is what exactly is happening in areas of the brain. So dopamine is a neurotransmitter. It plays a profound role in motivation and reinforcement. And some studies suggest that brains of adolescents basally might have lower levels of dopamine, and that's why it might be a little bit, your teenager might be getting bored all the time. But when they're responding responding to stimuli and novelty, they are risk takers. They have selective focus on reward as opposed to attention on risks and punishments. And so in that milieu of brain development, when that rapidly changing neurons and connections, you introduce substances of abuse like opioids that target the limbic system and the reward pathway and the dopamine pathway, that kind of alters the connections of the brain. Especially in those that are at risk. Paul asked about risk factors. Well, if a child or an individual has anxiety and depression, and they are on an opioid and they find that is relieving their anxiety and depression, that sets them up for abuse and misuse and ultimately addiction.
So it sounds like any chance we have to delay the onset or the use of any addictive substance is really critical, and that to introduce it to young people kind of is a heightened risk factor, I guess, for potential addiction. And Paul, certainly in your work as the Drug Free Community Coalition Director, I know you've reminded us of that when it comes to other addictive substances, marijuana, alcohol, that it's so important that we can that children whose brains are developing in the way you described, that if we can avoid those the use behaviors, then that's a powerful thing for us. So I guess the key question then is for parents in the community is, if my child is experiencing pain, if they have an athletic injury, if they've had their wisdom teeth removed, what are my options? What are the preferred interventions that parents should be knowledgeable of when they're thinking about relieving their child's pain?
So to understand the different treatment options out there and what is the best approach, it's to know what happens in the body and the brain when acute pain or pain from injury is experienced. We typically call a pain from injury nociceptive pain. So that is pain, the primary cause is tissue injury as opposed to neuropathic pain, which the cause is actual nerve damage. But in cases of nociceptive pain, what happens, let's say you have a sprained, a pulled muscle, sprained ankle, there's tissue damage, and that causes intact nerve endings at the site of injury to become engaged and activated. And it sends an electrical signal from that site of injury right to the spine. And it communicates the message that we've been hit, there might be prominent danger. And in the spine, a second neuron picks up that message and sends it right to the brain, to an area of the brain called the thalamus, which is the grand central station of the brain. And it tries to, there's an alarm that is coming in, so it tries to sort it out. Is there prominent danger? What should I do with this? And at the same time, the limbic system gets engaged, and that's when suffering kind of kicks in from the brain, so from the pain. And so pain is, in a sense, 100% produced in the brain, our perception of it, our tolerance of it. So as far as treatment options, if you think of the analogy that pain is the alarm, so we have treatments that can rely on, regional block. So we have local anesthetics. Lidocaine is an example. And so it acts as kind of the nerve cutters, the wire cutters, cutting that alarm to the brain. And they can be pretty effective in relieving the pain signal. At the same time, in nociceptive pain, what happens is often a normal process where you have a release of chemicals. They are inflammatory chemicals, and that plays a role in tissue repair. So initially, these inflammation has a role in tissue healing and tissue repair. But at the same time, inflammation can also contribute to pain. And so surrounding areas, nerve endings that are normally not involved in transmitting a pain signal, they become recruited and release this kind of inflammatory soup, a mix of different chemicals that contribute to inflammation that can also be a cause for pain. And so the treatment medications that we have out there, there are very strong analgesic medications that can relieve pain, but also the inflammation from that are a class of medications that we find over the counter. They can also, you can get it in higher dosages, and they are non-steroidal anti-inflammatory agents, or NSAIDs. And examples of those are ibuprofen, which is the active ingredient in Advil, and Motrin. And another example of a medication that belongs in these anti-inflammatory, non-steroidal anti-inflammatory agent is naproxen, which is the active ingredient in the brand name Aleve. So these are, you know, two choices of anti-inflammatory medications that are available over the counter.
So it sounds like certainly the research base suggests that there are alternatives, viable, proven, better alternatives for student athletes. And then Dr. McKee, sort of at the practitioner level, so your experience at Bay State Medical Center, what do you see as the experience that young people have with pain relief?
Well, my practice really is to address people who have persistent, difficult to treat pain. But even in populations of patients who have been living with pain for a long time, patients experience acute on top of their chronic pain. And they are often surprised that we can go back and make use of acetaminophen and nonsteroidal anti-inflammatory agents to address that kind of pain. And often I will hear in the office, well, my doctor said I should try an NSAID, but shouldn't I be treated with a real pain medicine? The truth of the matter is, acetaminophen in a proper dose and schedule and an NSAID in a proper dose and schedule are the most appropriate pain medicines for acute and many types of subacute pain. It's only when we really are looking at people who have persistent, difficult to treat non-cancer pain problems that haven't responded to other strategies that we might want to look at an opioid analgesic. An example of something that we hear all the time is, well, I'm going to be going to a dentist and he or she has already told me that they want to give me a prescription for a medicine, for example, trade name Percocet or Vicodin afterwards. Well, actually, studies show over and over again that the best treatment for dental pain is actually an NSAID in an appropriate dose and schedule. And what you have to understand about the use of these agents when you're treating acute pain is how much time you expect to get out of the analgesic effect. So if a patient says to me, it didn't work, and they've taken one dose in the morning but expected it to last 24 hours, then there's an education issue that we have to get to, because in the case of ibuprofen, you might expect 2 to 4 hours out of the drug, and in the case of naproxen, you might expect 12 to 17 hours out of the drug, but there's also its relative effects. Ibuprofen is a very powerful drug for anti-inflammatory effect, and combining it in an alternating schedule with acetaminophen can make a very potent combination, alternating every 3 or 4 hours throughout the day.
So even beyond medical interventions, even beyond the more familiar acetaminophens that you described, what other approaches should parents be thinking about when their children are experiencing pain, whether it's related to an athletic injury or a trip to the dentist? What other things should parents be thinking about?
Yeah, I think the the mental and the emotional aspects of pain are really key, not only in older adults, but especially in teenagers. So as I said, pain is an alarm in the brain, and the emotional centers have definitely been engaged. And we find that certain non-pharmacological modalities of just quieting the pain, meditation, relaxation, humor, just kind of sitting in the corner and kind of meditating, have a profound role in dealing with that kind of the suffering aspect and the emotional aspect of pain. Now kids, it's not natural. You can't tell your child just go in the corner and meditate if that hasn't been part of their behavior and repertoire. So this can become an opportunity of teaching our kids coping and spiritual coping techniques and meditative techniques and what is pain and suffering, but at the same time really understanding the source and the cause of that pain, and understanding that our kind of emotions can also amplify
Absolutely.
pain.
Distractions incredibly important, and it's one of the most useful tools for young people. So it really is okay in the first hours or days after an acute injury to rest and distract yourself with a favorite movie or friends or a game or something other than focusing on the pain. It's also why many people feel as if they have more pain at night, because during the day they've been distracted. And now at night, as things start to quiet down, they may become more aware of the pain. And that's another good reason that you need to renew medicine often just before bed. But the message also is, it's the expectation. The natural history of pain is to go away. It always is. That's how we're designed. And in the first few hours or days after pain, there is a process of healing. And with all the inflammatory soup that's already been discussed earlier, there's going to be time that is necessary. And so it's really, when you're a pain clinician, it's really about understanding the natural history of the illness, and whether it's a sore throat or pain from a dental extraction or from an injury to the knee, is it likely to be 16 hours, 3 days, 10 days? But what we should see over time is that over time the pain gets better and better and better. I want to hear from somebody who has acute pain if that is not the case. If actually with time the pain is becoming more intense, or now there is new swelling, or there is a change in what the injured area looks like. And that could tell us about infection or rare problems of nerve dysfunction, something called complex regional pain syndrome. Uncommon, but I would want to hear about it early.
I was thinking, as you're describing the interventions, that makes sense, that it really depends on the individual child. And it struck me that it's similar to how we approach intervention in learning settings, so that if a child is struggling to learn, it's so important for us as educators to know the whole child and to know what works for that individual child, so that there's not just one solution that necessarily works. So it seems like there's some connection there. And Paul, you sort of straddle both worlds. You work here in a school setting, your office is right here in the central office, and yet you also work with practitioners and researchers, and you've helped us bring together these partners in the community to address these really, really important issues. How do you see it in terms of addressing the needs of the whole child, and how this approach to pain management makes sense really educationally, but also medically? Is that?
Yeah, it ties really well in with social emotional learning, I think. So you have to understand, where is my teenager at as far as their own social emotional development, and how can I work with where they're at to manage and navigate their own pain. And yeah, you have to be really in tune to where they're at and how familiar they are and comfortable with themselves and their own experiences and expectations. And I think in particular about helping a child where they're at with their own pain in that moment after an injury, after a surgery, but also wearing the advocate hat as a parent. So when your child is given 30 Percocet after an oral surgery, I hear from dozens of parents, well, we'll give one just that first night to see how it goes, and then that'll be it. And so questions then come to me of how do we, and where do we, and when do we advocate for our child not to be overprescribed an opioid? And so then Gila and Al, Dr. McKee and Dr. Sabetti, respectively, have brought up the idea of sort of navigating the pharmacy in a way that, can I have this many pills dosed now, and then you can keep the prescription open? And I'd just like to make sure I'm getting all that right. But can either of you speak to how to navigate sort of more responsible prescribing with your own child as far as administering the opioids?
Well, my bias would be that whenever you're dealing with a healthcare professional, whether it's an oral surgeon or whether it's an orthopedic surgeon or a primary care provider, when there's a discussion about using something other than acetaminophen or an NSAID, the first thing you should do is slow down and share history, family history of out-of-control use of any substance, alcohol and other substances, the young person's personal experience with any kind of trauma, the expectations, the known natural history of the problem, and then really talk about the individual risks. And I think that there is not a one-size-fits-all prescription for somebody who's just had knee surgery or a tooth extraction. And it is illogical that everybody should go home with 30 opioid tablets after a surgery. If somebody doesn't already have a chronic pain problem and hasn't already lived with a chronic medical condition, it is unlikely that they will even need to be treated with opioids beyond the immediate post-surgical setting.
Anything else on that, Sheila?
Yeah, I mean, I think it's very important for parents to become empowered to ask the physicians the right questions and how can they limit exposure of their teen's brain to opioids, to discuss the alternatives out there. And there might be situations where they are given a prescription opioid, but that it's very important that medications for their teens and adolescents be managed, that teens and adolescents are not in the position to be managing their own medications, even if it's over the counter. Sometimes we have the misconception that because they are over the counter medications, they are perfectly safe and you can take as many as you want, and that is simply not the case. So engage in skilled conversations with physicians, with your pharmacists. Pharmacists are there to educate and provide that avenue of support and health care. So when, even if you are kind of trying to decide which over-the-counter, medicine to use, engage in that conversation with your pharmacist. So when you bring the medications home, make sure it is stored and locked, that you're managing it with your kids and you're watching them. And then when the prescription is done, that it shouldn't be staying in the house. We were talking about different types of pain, and sometimes families might say, well, I'm just going to keep it because there's probably going to be another injury or someone else in the family might need it for pain. And the fact of the matter is that opioids are not good for all types of pain, and with every injury, with every pain, it has to be reevaluated to determine the cause and the best treatment for it. So as soon as you're done with your medication, dispose of it. And Long Meadow, through the close community and the Long Meadow Police Department has kind of these exceptional drug take-back days, and they will remove your unwanted medications and remove access and availability from the community.
And that drop box is open 24/7 at the Long Meadow Police Department entryway.
And if you have the situation where a young person has been given a prescription for an opioid, and this might have happened because things got ahead of you, and you've come home with a prescription that says for 30 tablets, you can tell the pharmacist not to fill the entire amount. So all prescriptions in Massachusetts today for opioid analgesics should say partial fill permitted, which was always the law, but we've made it very clear. And at the level of the pharmacy, you can have a dialogue with the pharmacist and you can say, I'm going to try 3 days worth of this medicine, so maybe I need 8 tablets, not 30, or maybe I need 10 tablets. And you can always do that. You should not be saying, I had to take home 30 tablets because that's what the clinician wrote for.
So Dr. Sabetti, Dr. McKee, I want to thank you for joining us today. I also want to thank and acknowledge Paul McNeil, as the director of our Drug-Free Community Coalition, for bringing together community partners from Bay State Medical Center, from Western New England University, the College of Pharmacy and Health Sciences. The idea of partnerships, I think, is such a powerful concept when you're talking about helping children avoid drug misuse. And you described the partnership at the child level that needs to exist between a physician and a parent. And again, so similar to the partnership that we know works in a learning center. You know, when parents and teachers and parents and educators are partnering and on the same page in terms of their child's education, we know that great things happen. So I want to thank you all for joining us today and for this latest edition of the Superintendent's Corner. Thank you so much.
Thank you for having us.
All right.